Hello, everyone. Bonjour. Buenos dias. Hodadak. My name is Marian Pitters. I'm delighted to be the facilitator for today's webinar. I'm here to introduce our expert speaker, moderate some questions from you, our audience participants, and ensure that the webinars progress according to the schedule so that we respect everyone's time. But first, on behalf of McMaster University, it's my pleasure to welcome you to the 5th webinar of the 10-part series, Expert Perspectives on Pandemics. We have participants from all over Ontario, Canada, and the globe online today. Graduate students, faculty from McMaster and partner institutions, as well as representatives from the Pan American Health Organization, PAHO, the World Health Organization, WHO, and some select invitees. Many of you are preparing to contribute your skills to mitigation of the COVID-19 pandemic. We welcome you all to today's compelling session. The COVID-19 emergency presents a global challenge to our healthcare systems, our economy, and our ways of living. In the face of this unprecedented global health crisis, McMaster is dedicated to innovation and collaboration in the discovery of solutions to help combat COVID-19. This series is integral to the Master of Science in Global Health. Experts will delve into topics including historical trends, vaccine development, the threat of antibiotic resistance, and Canada's research response to COVID-19. A quick overview of the 10 webinars in our series can be found at the link where you registered, globalhealth.mcmaster.ca/2020 webinar series. Today's session is Webinar 5, Ethical Dimensions of Quarantines, Isolation Declarations of States of Emergency, and Community Lockdowns. It features Dr. Lisa Schwartz, the Arnold L. Johnson Chair in Healthcare Ethics at McMaster University. A final housekeeping note before we start. Time has been built in for questions and discussion at the end of the webinar. Please use the chat tool to submit questions electronically, and note that while we may not be able to get to all of your questions, our speakers will aim to address them afterwards on the Global Health website. At this point, I would like to introduce Dr. Andrea Baumann. Andrea is the Associate Vice President of Global Health, Faculty of Health Sciences at McMaster University, Director of the Master of Science in Global Health Program, and the Director of the World Health Organization, WHO, Collaborating Center in Primary Care and Health Human Resources. In addition to her many awards and accolades, in 2018, Andrea's groundbreaking research and outstanding nursing leadership were recognized with her appointment to the Order of Canada, one of our country's highest honors. Andrea, will you please start us off with a few words about launching this webinar series? Chris, I think Andrea is muted.
She will have to unmute herself there.
So I will ask Andrea to provide her remarks later. Let me just move along. Before we introduce our speaker again, please put your questions into the chat box and we'll be sure to get those. Now I'll introduce our speaker. Dr. Lisa Schwartz is the Arnold L. Johnson Chair in Healthcare Ethics, Professor in the Department of Health Research Methods, Evidence, and Impact, and an Associate Member of the Department of Philosophy at McMaster University. Her research interests focused on humanitarian health ethics, research ethics, teaching of ethics in healthcare education, and global health ethics. When not thinking about healthcare ethics, Dr. Schwartz is an avid walker along with her dog. And like many of us during COVID-19 isolation, Lisa has acquired a new pursuit. In order to improve her concentration while on Zoom meetings, Dr. Schwartz has taken to knitting, every stitch of which would be fully endorsed by the celebrated Canadian knitter and highly focused actor, Ryan Gosling. Dr. Schwartz, we look forward to your perspective on the ethical dimensions of our various pandemic mitigation methods for 30 minutes. I'll provide you with a reminder at the 28-minute mark, and then we'll invite you to engage our global participants in a Q&A session for 15 minutes. Over to you now, Dr. Schwartz.
Thank you very much, Marion. I hope everyone can see me in the corner of their screens here. This is the first time I have ever had the opportunity to share a presentation with Ryan Gosling's name, so thank you. I'm very grateful for that warm welcome. And if people ask later, I'll be happy to show you the disastrous knitting that I've been up to. So I think I need to expand my screen so that I can see the screen a little bit differently. Okay, does that look right to everyone? So I'll also begin by thanking everyone. First, thank you, Marion, for the lovely and warm introduction. And thanks to Dr. Andrea Bowman and members of the Global Health Program. I'm delighted to be able to share this presentation with you. It seems odd to be alone in the room, but also knowing that there are more than 200 other people listening in. So I'm very grateful for the time. And there's so much to cover here that actually what I thought I would do is really take you through some of the experience, almost a catalog of the ethical issues that we have addressed as bioethicists here in Canada, but also working in the global setting. So I altered my title just a little bit to think about what is the future for us and how can we bring ethics into that context of moving COVID-19 and our response to COVID-19 on further. Trying to find a way to move my screen. Next one here. Yes. And also begin by the land acknowledgement that McMaster University works on the territories of the Haudenosaunee and Anishinaabe nations, and the territory that is covered by the Upper Canada Treaties, Dish with One Spoon Wampum Agreement. So you may have heard it floating. There are so many people who talked about it. I think there was even a New England Journal of Medicine article that used these terms of unprecedented times, with always the suggestion that unprecedented times warrant unprecedented interventions. I think that's true to a certain extent, but I don't think it necessarily is true for every intervention that people have called upon. And it's part of our role as bioethicists, my role as a bioethicist, to think about and stop and ask the questions, what is potentially ethically justifiable, and where should we draw the limits on things that are not necessarily so? So I situate that as the first question. And when I was trying to sort through the I guess the shape of the framework of the presentation, I realized that we were always starting with, beginnings, middles, and ends, and then also thought about what were the direct and immediate effects of COVID-19 in terms of direct effects to individuals, to large bodies, and to policy in healthcare. So in that case, I want to stop and take some time to talk about rationing and the effects of the measures that have been used for containment. We can also think about the indirect, or some people have called the collateral damage. These are the kinds of treatments in hospitals or in healthcare settings that have been, in a sense, prioritized out. They were the measures that were not considered to be urgent enough, or that people could be asked to wait to find support for, which didn't necessarily always reflect the perspective of the individuals. Also the changes to infrastructure, but I will spend a bit less time on these indirect collateral issues. I think we could do an entire session on those, wanted to spend more time focused on direct and immediate, and then come back and reflect on emerging and sustained changes, some of which are already being discussed in the reopening strategies, and many of which we're not really thinking about just yet, I think, as the legacy issues. What will COVID-19 introduce for us, and what will be long-lasting and lingering? So I will spend some time, as I said, sort of looking at the impact of, or the direct impact to our restricted freedoms. I think you're probably all wondering, and if you haven't experienced these things yet in your own region, the questions about triage and how we'll be doing triaging will be something that we can explore. I want to talk about the social burdens more generally and some of the issues that have surfaced in our discussions in the bioethics circles. Then talk a bit about policies, about rights, and explore the principles, which are actually we're going to start with. And then I'll go to cover two other areas, a tiny bit on humanitarian interventions, because that's where most of my own research resides, and some questions about research during COVID-19. And then, as I said, we'll move on to future considerations. So I'm starting with the principles because more often than not in a bioethics consultation and bioethics circles, this is where we begin. So principles are those things that we value. They're the beliefs and the preferences that are agreed upon within a community or within an institution as directions for guidance when we're trying to get things right. And so there have been many principles floating around. If you've looked at any of the bioethics documents or any of the papers that are circulating generally about COVID-19 or about previous pandemic or epidemic discussions, I think you'll find that there's a sort of a catalog of principles that pop up, and some of them become more important, I guess, more highly prioritized and valued in a given setting or decision, and others tend to be downplayed. But the ones that I think that are probably most likely to turn up and that are very significant and worthy of some attention starts with proportionality. So what do we mean by proportionality as a guiding principle in decision making? It's really about making sure that the effects of any of the choices, any of the limitations, any of the priorities that are set that mean that some things will be deprioritized, that these happen in a way that they don't unduly burden or cause harm to those people who will be sort of prioritized out. And so the proportionality, this sense of how can we make sure that the decisions appear fair and don't appear overly burdensome, and how do we mitigate any of those burdens at the same time? These are the sorts of questions that politicians and healthcare providers have had to negotiate quite a lot. I think you'll see or will have found in watching them through the media. Reciprocity is another principle that's extremely important in this context. We see it again quite a lot in discussions with healthcare providers or about healthcare providers and other frontline workers. What can we expect? How far can we expect their sense of obligation, duty of care, and professional requirements to take them in a stage where there aren't sufficient resources and needs are definitely outpacing those resources. So the big question has been around frontline workers. How much can we expect of them if we don't, for example, provide adequate personal protective equipment or PPE? And that question of, can a doctor or a nurse, can a grocery store clerk be asked legitimately to function and to take on risks if we ourselves are not prepared to reciprocate by ensuring that they're safe when they're doing it. Another aspect of the reciprocity principle has been questioning whether healthcare providers should be the front recipients, the first recipients prioritized for healthcare should they become infected. So once they're taking that risk, should they be given ample opportunity? And I've heard my bioethics colleagues say, well, you know, it sounds like that's a great idea, and we should certainly promise that there will be some kind of care available, but how do we prioritize in a circumstance like that? Can we be sure that it's only the healthcare providers who are at the most risk? What about the grocery store workers, or what about people who work in sanitation, who remove the garbage from our streets? Are they not equally susceptible, and are they not equally significant and important in this response? And if that's the case, do we also owe them a sense of reciprocity? And the final category of people that we think about in terms of reciprocity is all of us, it's everybody. So if we are taking on the responsibility and the burden of self-isolation, and for some people that burden is greater than others, should we be expecting or anticipating some sort of reciprocal requirements? And I'm going to come back to that in a bit when we talk about the requirements of isolation later on. Among the others, I won't go into too much more detail because I think we'll be coming back to those. Utility is about making the best use of our resources. How do we do that? Decisions need to be relevant based on the best scientific evidence base, but also on values of the community, shared values of that community. In our communities, I think more and more we're seeing that fairness and equity is at the priority, that we want to make sure that everybody is treated in an equitable fashion. And again, we'll come back to that discussion. And I think very acutely non-abandonment, which is something else that I want to come back to. I'm going to leave the rest for now and move on to the next slide, because I think some of this will become more realized. I will just point out that at the Government of Canada, on their COVID website, they listed also guidance principles for pandemic preparedness, as well as research and other events going on. And I think you'll note that, I was quite pleased to see this, that many of those principles, although they may be called something different, the concepts are very much the same. Rather than talking about solidarity, I'm glad that they've shifted to collaboration. They've talked about evidence-informed decision-making and being responsive to new evidence, to proportionality, flexibility in that response, using the precautionary approach of being timely without being overly protective, and the use of established practices and systems, and of course, ethical decision-making. So I think each of our countries have probably got the same sorts of expressions. Whether or not we're all able to live up to those and how we go about doing that, I guess it'll be a question for reflection later on at the time. But probably the most poignant of the issues that emerged most rapidly at the front of the pandemic were the experiences that we saw somewhat in China, definitely in Italy, around triage decision-making. And if you were to ask me right now what was one of the most vexing of the ethical questions that we encountered in this, during COVID-19, I think the triage aspect is probably the most severe. We've been fortunate in Canada that although we've reached peak in some regions, it's been hard. I don't think that the kinds of decision-making at sort of the strong ends of triage have materialized, and I'll be very grateful if they never do. But it's always a possibility, and if not in this outbreak, then in others. And that's why it's really important for us to know more about how triage decisions get made, what is the criteria for making those decisions, and very importantly, what the lived experience is of the frontline providers who had to make those choices, or who were maybe assisted or sometimes not assisted to make those choices. So we put together, along with colleagues, Dr. Sonia Dalat, who's on the line here, a member of the Global Health Program, also Dr. Élisée Nouvet, colleagues, Pat Strachan, also from School of Nursing at McMaster, but then also colleagues in Italy and other regions who participated in a study, a rapid study that's been guided by the World Health Organization, on triage and how it's lived out by the experience of healthcare providers. So we wanted to know more about what treatments will be offered to critical care patients for whom there will be no equipment like ventilators for their, for their continued survival. And so when a decision was made about those patients who would not receive life-sustaining treatment, what happens to them? And I can tell you this is really important because any number of documents that I saw from various different regions and various different organizations that talked about triage had a tendency to specify the, the pathway towards either you receive or you don't receive active life-saving treatment. But when they reached the point of, okay, no ventilator for this patient, it stopped there. And there was no clear guidance about what would happen to a patient who didn't receive life-sustaining treatment. So we really wanted to explore what that meant and how the policies could be created so that people would be left with nothing to die on their own on units without support. The kinds of considerations that we're beginning to see, I have to say we can't give you any data yet because we just finished interviews last week and we're in the middle of doing our rapid analysis of the data. But I can tell you that just in the inklings from my perspective of what I've heard, that there's no doubt about it that healthcare providers need support, especially when they feel that they're forced to make these decisions, the playing God decisions, if you will. They were all, of course, reluctant to have to make that choice. They didn't see it as a continuum of their training, let alone preparedness for making choices in like care management for patients. Many of them already felt burnt out, under-supported, and depressed about the experiences that they were finding. And I guess today we saw that a second physician suicide linked to COVID-19, in both cases hearing stories about doctors who felt ill-equipped to manage these very difficult decisions. We know that part of what needs to be salvaged in all of this is some direction, some creative recommendations. And there's no doubt, as we're going to revisit in a moment, that the reasons that a decision should be made should be specifically on clinically relevant reasons for withdrawing or withholding care from a particular patient. That's the way it functions most of the time. But of course, in the midst of a pandemic with shortages, as it is the case in many humanitarian settings, sometimes the clinically relevant decision gets moved on to a resource allocation decision, and we simply don't have the resources to provide. And so the participants in this study are talking about their sense of duty of care towards patients and a strong commitment to non-abandonment of those patients. And so, I think too that in the midst of it, the discussion generally, broadly, became one of how are we making those decisions and who is in the right position to make those decisions and under what criteria. So it wasn't surprising when the Ontario government received a letter from disability rights organizations, including Arch Disability Law Center, and as many as 204 other organizations with over 4,000, almost 5,000 individuals signing this letter, urging the government to make sure that any decisions about healthcare resource allocation would be made primarily on clinical need for the particular patient, and not on generalities that would deprioritize persons with disabilities who need critical care and would not seek it, would not be able to receive it because of comorbidities. So this became very crucial. The wonderful thing about it in our experience of it was that a version of the, a draft version, very cold draft version circulated without our anticipating it doing so. And it hadn't been approved at the bioethics table anyway The good thing about it, though, was that it was, even though it was highly flawed, it opened up this kind of conversation. And I don't think we would have had 5,000 individuals come together to sign a letter if the discussion hadn't emerged. And of course, the latest versions of priority decision-making in pandemic take into consideration this feedback. So it's an important lesson that probably didn't happen the way we would have liked, but at least it did happen. In the end, our conclusion about that is that palliative care is very important in pandemic response. We've seen articles coming up about that. I was honored to be a member of the panel for the International Association for Hospice and Palliative Care Medicine, and also the group called Palliative, who wrote an ethics statement, and in that statement very clearly indicated that palliative care must be provided to all patients who need it regardless of prognosis, and is ethically imperative for those not deemed eligible for life-supporting interventions. So fortunately, there's that sense that if there is a pathway that ends in you're not going to receive the life-sustaining treatment, then at least we know that individuals won't be left to die by themselves untreated and suffering and alone. But that the palliative care initiatives, which have to be planned in advance, will be available for those people who are not likely to survive for pandemic reasons or for any other kinds of reasons. Which opened up the next stage of the problem, care and distance. This is an image from the DRC, from the Ebola outbreak there. We saw it many times in West African outbreak, that family members would be distant, wouldn't be able to come to be at the bedside of their loved ones, whether they were going to survive or not. And so these additional challenges of physical distancing and isolation can affect patients and their loved ones and their care providers. And we know this for sure because we've seen the secondary trauma that happened in the Ebola crises that led to individuals losing trust in healthcare providers and in leadership, feeling distraught and unable to manage, at not having been able to be at the bedsides of their loved ones. So it follows that a dear colleague, a highly respected colleague, Dr. Kevin Bezenson, who's based in a hospital here in Northern Ontario, he was very anxious and upset about what he was witnessing and wrote to the Toronto Star newspaper a short article called "We Don't Have to Let Our Loved Ones Die Alone." And there he indicated that he said, "I believe in most circumstances for patients nearing the end of their lives due to COVID-19, we can and should seek to support a physical visit with personal protective equipment for a representative family member or loved one." And he goes on in this article to describe ways in which he thinks it could be made possible, and that we should be prioritizing PPE availability for loved ones so that individuals don't have to die alone. And in the midst of all of that, we began to hear terrible stories, at least here in Canada, of the difficulties that long-term care facilities were facing. And we hear much less about it, but they're still circulating problems of home care. And these are important lessons. I think we should have seen it coming. I guess we did see it coming in the situation in Italy, and when it finally reached here, I think we were ill-prepared for managing long-term care facilities in these contexts. But of course, we know that in global setting, while there will be other long-term care facilities, it's more likely that home care will be the place. And to be honest, I've also heard stories of people here in Canada saying that they prefer not to go to hospital or to be admitted to long-term care. Sometimes they're actually bringing parents and grandparents home to look after them because they prefer not to die alone without being able to be near their loved ones. So we have to account for, and I think there is an ethical obligation for us to respond to supporting informal care providers, whether they be in the long-term care settings or in home care. We don't have that kind of insight developed just yet, although I think we saw it very clearly in Ebola and should be able to learn from those lessons and transfer those lessons over. So people, again, feel under-supported, certainly under-resourced. They're asking questions like, how do I protect myself from infection? How do I keep my home clean? Many of the hardest hit and most vulnerable people are the people who are either in long-term care or in receiving care at home. And they are the most likely to be infected by COVID as well. So as I said, some people are opting to stay in place as long as possible. They're saying that they'd rather die at home than in overwhelmed hospitals. And I think it's incumbent upon us to start planning now to ensure that this doesn't happen again. Those of you living in Canada will know that we've called in, both drawn on the Red Cross and also on the military to help supply support. And I think we could be doing better than emergency response in these times. So just to shift over, going back to what I initially was talking about around restrictions of liberty and what does it mean for us to take that sacrifice of staying home. In Canada, we have had very severe, I guess, or fairly severe restrictions, but mostly voluntary at this stage. We're allowed in our region to go out to go shopping, one person, one cart in the grocery store. So we go out to groceries, not to wide markets or open markets. Still, there are frontline workers there who have to look after things. And for people like me who like to go out for a walk and take our dogs out for long walks, that's been an option in my region at least. Others have faced much more strict restrictions, and I think there's been some concern about either governments or even local officials taking on the restrictive measures, more restrictive measures than necessary. And remember that that we want to keep that balance. So the concerns about restrictions to liberty have been discussed. And most recently, I think about 2 weeks ago in the New England Journal of Medicine, a specific statement about, despite their breadth, the federal and state quarantine powers are subject to important constitutional limitations. It's important to recognize that most governments do have to face these limitations. They can draw on emergency acts to override certain limitations, but for the most part, they need to be strongly justified. And so in the United States, and it's the case here in Canada, this usually has to be voted upon, and there has to be general agreement. And one of the things that Parmet and Shinha indicate is that part of the concern has been that the quarantines are unfairly applied. So they're saying that quarantines cannot be imposed in a racially invidious manner, and also that governments must have a strong basis for those restrictions, for any restrictions. And I think these considerations have to be taken into account. The good news about it is that at least in liberal democracies, we can challenge, and we have been open to those challenges. We've seen the protests as well, but we hope that the decisions will be, eventually founded on good, scientifically evidence-based decision-making. I think we can see across the world that even where there are some relaxations, we've seen spikes even in Wuhan in China, where they were concerned that travelers coming back or coming from elsewhere might be responsible for that. So we also have to worry about stigma in all of this. It's quite a big circle of challenges. But with relation to the questions about liberty and democratic process, within all of that, yesterday I had the opportunity, because I'm working with World Health Organization on a couple of panels, and one conversation with a group of social scientists from WHO and from around the world lingered for a little while on masks and the benefits and the drawbacks of individuals being asked to wear masks. One of the first things we have to think about is, why are we wearing the masks? Is it for personal protection, or is it as a source of control? Is it to protect other people around us? Some people pointed out that in certain countries, masks are a regular occurrence, partly due to pollution, partly as lingering effects of SARS. There are people who wear masks routinely every time they go outside. And so for some, it's considered to be a kind of solidarity, whereas for others, of course, there's the associated stigma, that sense that a mask is designed originally for concealment, and it conceals, regardless, it will conceal the identity of individuals. And so, you know, how we use them is not necessarily as simple as, okay, I'm just going to don a mask now. For some people, it has real disproportionate effects. There's the question about availability, the question about cost and access, but also who is it that's most susceptible and most vulnerable and needs to wear masks. Somebody pointed out that it's usually people who have to either work in overcrowded spaces or spaces where they can't avoid either touching or being near people. We're seeing that now in the States with the barbers opening up. And also the people who have to ride crowded transport to get anywhere, and that will be very much the case in the low-income countries now, in the middle-income countries, as we see things opening up or persisting.
Lisa, there's about 2 minutes left.
Okay, so I'm going to skip over from there and move on to other slides, because I think we can move on to that. But I did want to point out, first of all, the problem associated with the stigmatization of wearing masks. Because I think we're hearing now and again people talk about pandemic as a democratizing event, and it's really not a democratizing event. So, you know, when this article came out in the Boston Globe, I think it opened up a lot of concern about the question of equity and fairness in how we mitigate and respond in pandemics. So like any other disasters, as my colleagues Rioa Chung and Matthew Hunt talked about it, disasters don't affect people equally, and we should be very aware of that when policies are being decided. That vulnerability to catastrophe is determined by social, cultural, and economic factors, and catastrophe widens existing inequalities. So we should be aware that social vulnerability means that we have to respond differently and more intensely. For people who have chronic illness and disability, we should also be more attentive. And we have to realize that the struggles of family life, the struggles of just homelessness, all of those things are managed differently. And so the restrictions affect people in different ways. In the humanitarian sector, it's been interesting because they say that they can't deploy. Nobody's allowed on airplanes crossing jurisdictions into other countries. So it was unusual for them to find themselves running projects and responses in their own home countries. And they wondered about what the purpose of that was and what particular value aid organizations had to offer when they can't deploy, which is a question I think is worth discussing in the discussion section. So we've talked about human rights issues, and I think another consideration will be to, in our responses, include the health in all policies approach. I think that's a slightly imperfect approach, but in pandemics, it's probably more important than ever before. I'm not going to spend time on research ethics now because I think there are many issues that we could come back to. And I really just want to leave you with a couple of thoughts. One of the big questions is going to be how we end up measuring success in this pandemic. I'm not even sure if we have seen successes yet. It seems like we do when the things drop, when infection levels drop. But we won't know really until after the fact how we're going to measure success. I do know that I hope that success does not end up just a reopening and return to business as usual. My sense about it is that business as usual was not working very well. It didn't represent equity well enough. We didn't have this sense of compassionate response for one another. And I think we could be doing better on that. So on my last slide, I just want to leave you with this image from the Kigali Genocide Memorial Museum, which has the word associated with it, Ubuntu, which is in Africa the philosophical concept or ethic of interconnectedness. And it translates into English roughly as I am because we are. So I think when we do reopen, we should be taking an ecological approach, a sense that we're all part of this together and that we shouldn't be leaving anybody to linger without in an inequitable situation if just in order to make sure that we ourselves are safe. Let's stop there.
Dr. Schwartz, thank you so much for that, and thank you for curtailing some of your comments there so that we can get to the questions and answers expeditiously, and they're flying in here. So everyone, I just want to remind you to submit your questions in the chat section. There's so many dimensions to ethics, as you have pointed out, and the questions reflect that. What I'd like to start with is one person's indicating that it seems like there's going to be a greater infringement on personal security following this pandemic, and they give an example of cell phone location of COVID-19 patients tracked by Google and Apple. What ethical issues do you foresee arising with this? So I'll repeat that again. It seems like there's going to be a greater infringement on personal security following this pandemic. Example, cell phone location of COVID-19 patients tracked by Google and Apple. What ethical issues do you foresee arising? Now, that's a huge question. I know you could take all day. I'm wondering if you could highlight one or two ethical issues that you foresee arising in that particular situation. Thank you.
Thank you. Yeah, and it is a big issue, but just quickly to say that, you know, first of all, we have to put ourselves in the sense of reality. Most of us are already open to sharing private data in various different ways. And anybody who has Facebook, I don't, but I'm on Twitter. I do carry my cell phone everywhere. When we take walks, my husband always wears his Apple Watch. So I think we are potentially open to security and privacy breaches in ways that we should be very attentive to. And that's not just a problem for COVID. The question then will be, you know, are we singling any particular people out? And I think that's where we need to be very cautious. Where contact tracing is very important, we have ways to do that that doesn't necessarily have to impinge on personal liberty. So I would be asking, how far do we really need to go to manage this question electronically when we've had methods for doing contact tracing for hundreds of years, and they've been very effective without infringing on individual liberty. So that would be my first question. I would want to know for sure, is this necessary? And what will be the limits of, what measures, I guess, will be taken to limit the access and the abuse of this information further on.
So just to get a sense of how you responded to that, earlier in your presentation, you cited a number of principles that are important to use when you're taking an ethical perspective. And then you focused on what the Canadian government had put up on their website. Is that what you just did now? You went back to those particular principles and figured out, all right, we're talking about personal security here. What principles do we apply for this? Is that what you just did?
Exactly right. Yeah. So thank you for bringing me back to those first principles. So, you know, quite clearly, proportionality is one of those principles. If we're going to use personal and private data for any purpose, we need to know that there will be limitations and that only that data that is necessary will be shared with only those people who need, and that the individual has given agreement for them to use it. And these again are principles that are not new, they're not invented, but they're just as likely to be useful here. So we have to go back to those. We have to go back to principles of beneficence, of doing good, of individual autonomy, so that the individual understands what they are consenting to or agreeing to, or understands that this is too urgent an issue, and so their agreement won't be sought, but they will be protected through proportionality and also through reciprocity. So, and then I guess there'll be other aspects of transparency and accountability of the agents and the agencies that have access to that data. So yeah, absolutely right.
So the questions are pouring in here. One that certainly comes up over and over again is around mental health. So this question asks, how is mental health implemented in decision-making when deciding on restrictions and isolation? So the question is, how is mental health implemented in decision-making when deciding on restrictions and isolation?
That's a very good question. I guess as an ethicist and a philosopher, I can't give you the medical detail, and I think that would be a question to ask people who have expertise in psychiatry and psychology who can help with that. But so my answer would have to be that any decision made of that sort needs to take into consideration evidence and the principles of things like non-abandonment, so that individuals who are asked again to take these kinds of make these kinds of sacrifices will be responded to. I think we've seen that a little bit in, well, quite a lot actually, in the response that the Canadian government has been making. Again, it's probably not perfect because I think there are still some people who are left alone and abandoned. But part of the response has been to ensure that individuals aren't worried about their financial settings or situation. Attempts have been made to help people manage their finance. There are probably other ways and maybe grander gestures that could be made in that direction. But at least there is some attention paid to it. We're not just abandoning people and saying, sorry, you're just going to have to live with this. So anytime an individual is asked to make a sacrifice of their liberty for the greater good, we will also have to, engage in the principle of reciprocity and understand that if they're making that sacrifice, if any of us or all of us are making that sacrifice, we need to be constantly aware of and attentive to who's being negatively affected by that, and how can we provide the care and response that is needed to make sure that they don't get lost and don't end up further suffering and injured because of it. And mental health, of course, would be very high on that list. I think in the end, we'll probably look back and see that mental health was one of the greatest injuries and some of the worst suffering sustained in COVID-19 because it will be so widespread. So finding ways to support people will be necessary, and that will be an ongoing project.
This next question builds on the previous one, Dr. Schwartz, in that it's about people need to work every day to eat, in particular in developing countries. Thus, they're forced to make the decision of staying home and starving or working and risking COVID-19. I was wondering if you could speak on this and what you think could be done to combat these problems. Again, another huge question, but let me repeat it. In many developing countries, people need to work every day to eat. Thus, they are forced to make the decision of staying home and starving or working and risking COVID-19. I was wondering if you could speak on this and what you think could be done to combat these problems. A couple of things there that come to mind.
Yeah, you're right. I mean, I think it's probably one of the biggest considerations facing us. And even just this morning, I was reading something about how in conflict zones, COVID-19 is just another layer of challenges that some people are having to live with. And I suspect, I mean, my first thought about that is that it's another layer, and it's probably not even the worst danger that most people are confronting in some settings. In the low-income countries, there's no doubt that being able to feed your family, feed yourself, respond in ways that are necessary is something that will be even more significant than the issues that we're facing here in the sort of higher income, higher resource countries. Sometimes I think that our decisions, and they were terrible, related to resource allocation and ventilator distribution, will seem very small by comparison to the kinds of decisions and issues that are going to be faced in very low resource settings where, as you described, people need for their livelihoods to maintain connections and go out in the world. I think that's why I wanted to close on that concept of Ubuntu, because our relationship with the rest of the world needs to be reconsidered at this stage now. We haven't heard very much about spikes in COVID-19 presence in infection in low-income countries yet, but that's probably mostly because nobody can afford to manage the testing, and so we're just not seeing the numbers quite in the same way. But our first responses should be to share the resourcing that we have, to make sure that as members of the high-income countries can provide support, and whether it's personal protective equipment on a large scale, which we're now able to produce for ourselves more and more, or if it's attention to medications, access to the vaccines that are being developed, we'll have to make sure that that response is made available in ways that are cost effective, but more importantly, like not even about cost. They should just be made available. We should be looking at this ecological approach. Our interests all will be shared, or so will be improved if we share in that sort of way. So there's a collective response, I think, that needs to be attended to, and it's very much been on the plate for the humanitarian aid organizations, but it really needs to make it to the governments right now, so that that sense of sharing and shared interest comes to fruition.
Thank you for that. The idea of giving something up so others can benefit is a theme that's coming out in the questions. And this one in particular says that in an ideal world, we would hope that individuals would voluntarily subsume a portion of their autonomy for the greater good. For those who don't share this sense of duty, do you think there is a rule for government in encouraging such an approach? If so, what would be the ethical argument? And again, that's a huge one. We just have a couple of minutes left, so let me read it again, and perhaps you can pull some highlights for us, Lisa. In an ideal world, we would hope that individuals would voluntarily subsume a portion of their autonomy for the greater good. For those who don't share this sense of duty, do you think there's a rule for government in encouraging such an approach? If so, what would be the ethical argument?
It's a really excellent question. I will say that personally, yes, I do believe that we should. Human beings are social animals. We live in communities, and we rely on our communities, no matter how distant we feel that we want to be from them. We rely on community to keep our lives going and make our lives better. So if nothing else, then I guess I would think to turn to John Rawls's arguments about enlightened self-interest, understanding again that we are part of that same global community, that it's not enough just to look to ourselves, to our own, and to live locally. I think we have to think about those local obligations, but we're in a globalized world. We'll be aware, we will know about the suffering of people in other contexts, and if we know about it, we have an obligation to respond to it. So I begin with enlightened self-interest, mainly because, as an ethical argument, mainly because it speaks even to the selfishness, let's say. It's understanding that we, that I am because we are, and that we have to respond to general interests in order even to preserve our own interests. And then I would also think about, taking a more ecological approach so that we can see that the benefits, I guess, of compassion and mutual interdependence for one another are necessary for everybody to be lifted out of this problem, rather than the sense that we will step on others in order to improve our own experience. So, yeah, I think I would leave it at that.
Thank you. Just one last question I'd like to sneak in. That one focused on a global community, if you will. This is a particular community that this question comes from. In my area, over 1,000 prisoners have been released due to COVID-19 concerns in prisons, while at the same time, non-incarcerated people are being faced with prolonged and greater restrictions on their movements and freedoms. At what point does quarantine become tyranny? Just let me read that again, it's a bit long. In my area, over 1,000 prisoners have been released due to COVID-19 concerns in prisons, while at the same time, non-incarcerated people are being faced with prolonged and greater restrictions on their movements and freedoms. At what point does quarantine become tyranny? We've got about 1 minute for you to give that big answer there, Dr. Schwartz. Thank you for taking that on.
It's probably one of the toughest ones, and it's a strange kind of irony. Definitely we needed to do something to be sure that people didn't suffer unfairly there, but we're also seeing, as I said before, the potential for power grabs in some contexts to override the freedom of individual, ordinary citizens in ways that are, that are unnecessarily restrictive. So I'll take us back to the principle of proportionality, and recognizing that we have to come to bear, that we have to put pressure on our governments, ask the questions, and always make sure that the restrictions are proportional to the need. And some people will do that willingly, and others may not. And I think that will be a question for later on. Some people in Toronto were being fined for walking out on the streets and not taking the proper precautions. Many people criticized that, critiqued it, and said it's, it's just not fair, and the burden might be placed unfairly. So looking for ways that are not tyrannical, but that approach things, again, with compassion and understanding, I think will make a big difference. Question authority for their proportional response.
Thank you so much, Dr. Schwartz. I appreciate you answering those questions. Thanks, everyone, for the questions. Of course, we didn't get to all of them, but you'll see them posted on the Global Health site, and hopefully Dr. Schwartz can provide some more insight into those. A special thanks to you, Dr. Schwartz, for an excellent presentation and for the insights provided in the Q&A with our global audience. We really appreciate your distinctive contribution to this webinar series. And now let's quickly wrap up. Thank you all for attending today's session. We look forward to hosting the 6th webinar entitled Flattening the Curve on COVID-19, Country-Specific Comparisons. This will be held on Wednesday, May the 6th, that's next week, from 12 to 1 Eastern Daylight Time. Now please note that that time changes from the webinar we did today, which was at 10:45. So this is switching to 12 noon Eastern Daylight Time. It features Dr. Om Kurmi, respiratory epidemiologist in the Department of Medicine at McMaster University. And in this webinar, you'll learn about various countries' approaches to flattening the curve on COVID-19. If you haven't registered for webinar 6 or other webinars in the series, just go to the link on the website globalhealth.mcmaster.ca/2020 webinar series. So enjoy the rest of your day, everyone. We look forward to your participation in our next exciting webinar. Thank you. Merci. Gracias. Dank u wel.
Thank you very much.